Okay, good afternoon. Some of you look like I see familiar faces. Some of you have been to this series before. It's sort of like a never-ending tape because the topics change, the speakers change, everything changes. Some things are topics keep recurring because of their major importance. So permit me to just spend a couple of minutes for those who maybe this first time they've been here. So we start out with a quiz. What's that? Don't answer if you've been here before. Like, it's a bridge, right? Okay, what bridge is it? Most famous bridge in the world. What? It's also the most wonderful, cheapest date in the city of New York. You take a bottle of wine, a loaf of bread, some cheese, and your boyfriend or girlfriend walk across the bridge in the late afternoon. Unbelievable. Yeah, that's the Brooklyn Bridge. This picture, as a side note, was actually taken by my grandfather in 1870-something using an old-fashioned box camera. Now, the reason for the bridge is the reason why we have this course. And one can wax on and on using the analysis of a bridge. But the point of it all is that the major problem confronting biomedical science today is a communications one. It's that people on one side of the bridge, namely the basic scientists, have incredible skill, accomplishment, in a very reductionist way for the most part. And those who are on the other side of the bridge, who may be clinicians, particularly out in practice, have great difficulty understanding what the first group is talking about. And there are some barriers among the first group that don't exactly cause them to get too excited about what is going on in the bigger area of human health. So the big challenge is not to fill your heads with a lot of sort of medical school facts that you're supposed to memorize and so forth. It's to excite. So the purpose of this whole course is to excite your interest in what are major human health problems and where we stand in terms of the linkage with what's going on in a more reductionist basic science view. And I can tell you that there have been many examples where people, postdocs, have gotten so excited about something, they've actually gone on and pursued it with some of the investigators, although this is not intended to be an alternative job market. But it does point to a very important thing that you PhDs are not aware of, and that is the third major job market in the United States is actually in clinical departments. Not like in the old days where you worked for an MD. That's gone. Now, most schools have changed the rules, so you're kind of working with. In other words, you have your independence. And we'll talk about that. That's the point along the line. But somehow that gets neglected, and most PhDs don't realize that's the case. There are now 17 full professors of medicine in the United States who do not have an MD degree. And most of them are in major medical centers. Now, their story is a very interesting one that we can address at some time. So, the course is posted on the website. You just Google Demystifying Medicine. You'll see the whole program, and we try to get several days ahead of time a brief CV, who are the speakers, a few selected references, and if a field is, totally unknown to you, but you read about it in the papers or it's exciting, look at some of those papers and you get a little background. And then all the PowerPoints are there, so you can actually see. Roughly about 100 people come on site, which is great because you get a chance. There's lots of room for questions and discussion. And if somebody says something that you really don't understand, speak up. We're not trying to cover You know, this isn't like a high school curriculum these days where you have to cover every subject. That's not going to happen. So speak up. And so we, really encourage you to do that. What else? If you come to better than 50% of the sessions and sign in, at the end we have a not very difficult electronic multiple choice exam that you can take over and over again. And if and when, well, when you pass it, you'll get a certificate from the NIH saying that you attended this course in pathobiology, Demystifying Medicine, which has apparently some value in the real world. It's not like a PhD degree or anything like that. The last thing I'll mention is that most of the time we have a live patient who starts out and spends 5-10 minutes telling the story of what his or her disease is in their own words, not medical jargon. And it's interesting, when we conducted a little poll amongst the people who watch and who are attend here, that live patient was a major driving force. Puts a human face on the disease, as one student put it very well. And then there's an outstanding clinical investigator. Most of the speakers are from NIH, which is a gold mine of this kind of activity. I'm sure you know we have the world's largest research hospital just up the road there. And if you don't know, you should go see it. It's phenomenal. So there are many people who work there doing clinical research, bridging the gap, and so forth. So those people will speak. And then a basic scientist who's also at the cutting edge of what's going on. But their talk is not a research seminar. It's not yesterday's experiment. It's where the issue is today. What do we know? What do we don't know? And where are we moving? And it's really very exciting because you're going to hear things that won't appear in the published press for a year or more. So at any rate, and if you have any questions or so, you can contact me. My email address is on the demystifying thing, or give me a ring or anything. And I encourage you to sign the sheet. The information is top secret. It doesn't go to any security agency or anything. We just use it as a guide to get a clue as to who's actually here and also on the website. Okay, so enough of the Brooklyn Bridge. So today we're going to talk about attention deficit hyperactivity disorder, and I have been looking forward to this for a long time. As a physician, although I don't see patients these days, but family, friends, and so forth, their kids are taking drugs, not narcotics, but stimulants, because they have what the doctor says is ADHD. I recently spoke at 2 high schools, one a very fancy private school in New York City. Over 40% of the kids in the class I was speaking to were taking drugs because of this. And the other school was a not so well-off school in a somewhat different, what you might call, I don't know, lower middle class or something like that. And about 20% of the kids that were there, these are high school students. So I'm confused. You know, what is this? In the old days, in the pre-bacteriology days, physicians diagnosed pneumonia. And it was only many years later that they, could identify there are probably 100 different agents that cause pneumonia. It's syndromes versus symptoms versus diagnosis. That's one of the huge challenges when you get into complicated disorders like this. So you have symptoms. Does it mean if a kid is very fidgety, can't sit still, raises hell at the dinner table, doesn't do his homework, gives you a hard time, and you're a parent who, by God, my son is going to go to Harvard no matter what. Is that the setting for ADHD? So it sounds like a very complicated situation. And in my reading, I'm not clear how you do diagnose it. And if you do, when do you treat? Should all these kids be taking drugs? Is it good to be taking these stimulatory drugs for years? I don't know. I suspect you don't know either. But our speakers today know, and that's the point of the whole thing. At least I hope they do. Okay, so we're very fortunate because, again, here's a beautiful example of this bridge building business taking place here at the NIH because, if you read in the literature, two of the names and studies that keep coming up are names of our speakers today, Max Muenke and Philip Shaw. So I'm going to tell you just very briefly about you. Max is a physician who graduated from medical school at the Free University in Berlin, trained in pediatrics, trained in genetics at Yale, more pediatrics and genetics, was a tenured associate professor at the University of Pennsylvania, and then came here in the Genome Institute to head a unit that is related to bridging genomic analysis with complex diseases. And his main work has been on craniofacial distortion, bone formations, and so forth. And he's identified genes specifically associated, and several years ago turned his attention to ADHD. And he's certainly one of the leaders in this field. So Max is going to speak first, and the second speaker is Philip Shaw, who took his medical training at Oxford and also in psychology. And he, in various places around the world, Australia, the United States, the United Kingdom, was trained in psychiatry, in pediatrics, in psychology. And Philip's approach is completely different. And recently he won one of the really highly competitive awards here at NIH, a Stedman investigatorship. And so he's going to follow up and speak not so much about the genetic aspect of it, but other aspects that deal with how we understand this disease. So enough of me. Thank you very much for coming.
Okay, good afternoon, everybody. I'm just delighted to be here. I'm delighted to see this many people here. I quite frankly thought I knew Phil would be coming. I knew that Win would be coming. I didn't know how many of you would be here. So I'm really pleased you're here. Just today I thought about when we started the work on ADHD, and it really started on a vacation while my family and I, we were at South China Lake in Maine. And we were at this wonderful lake and sitting there, and everything was just very calm. And we had in the lab at the Children's Hospital in Philadelphia, had just this major excitement. At the time, it was still very exciting to clone a gene for a human disorder. So we had cloned a gene that has to do with bone growth, with how the skull is shaped, craniosynostosis. And I thought, if we can do this, we can do anything. You can tell there's a little bit of megalomania in there. And then before we went on vacation, I inquired, I looked what are common problems in pediatrics where the underlying genetic basis is not known. And at the time I thought about dyslexia, I thought about reading disabilities, I thought about stuttering, I thought about autism, and I thought about ADHD. And after 2 weeks of staring at this lake, South China Lake, I thought ADHD is it. And then we got started at the University of Pennsylvania and Children's Hospital in Philadelphia, only to find out the problem is so big you can't do it in one lab. It's just huge. And that was the main reason to come to the NIH. And when I still remember when I had my interview at the time, our institute's director was someone named Francis Collins. You may have heard of him. And he was someone who asked, so what's the heritability factor? I'll tell you what a heritability factor is. And he said, and then I told him and said, oh, that's higher, as in there's more genetics to it than to diabetes, which he is studying. And I guess that kind of did it, and then I had the position there, and then I started working in 1997. So if I can move this forward, I will. Okay, I have no conflict, if anyone cares to know. What I will tell you about this, I will give you an introduction. The introduction today may be slightly longer than the main part, just because this is really connecting, bridging the clinical part with the basic science part and getting you all on board here. I will tell you about genetics of attention deficit hyperactivity. I will tell you about different genetic approaches, some that we have taken, some that others have taken. I will tell you, at least focus on one gene here. I will focus on a gene called LPHN3, not really talk about the neural cell adhesion molecule, just briefly, and then we'll tell you about pharmacogenetic studies in ADHD, and then how the first studies in the animal model have helped, or it's with the goal of helping us understand how can we use medication and other treatments to treat individuals with ADHD better. And all of this will be done in 35 minutes, and I think my time will be probably done in 30 minutes. So if I'm not done, I'll stop in the middle of it, because I have been only on one panel where I talked with Philip Shaw in the same session, and that was out of all places in Berlin, Germany. And so I'm looking very much forward to Phil's talk, so I promise you I'll stop at 10 minutes off. So most of you know what ADHD is. Either you have a colleague who has ADHD, you have a child who has ADHD, you have a relative who has ADHD, or you have a boss who has ADHD. So, but what it really is there's some definitions there: excessive inattention, hyperactivity, and impulsivity. And the important part is really given for a developmental level. So if a 4-year-old cannot listen to a talk for 45 minutes, perfectly fine. If a 40-year-old cannot listen to a talk for 45 minutes, maybe there are some attention issues, or the speaker is extremely boring. So there's a multi-point criteria, the DSM-V criteria for each category, which I'll tell you about in just a moment. You probably know that ADHD is the most common behavioral disorder of childhood. It's anywhere between 7 and 11% of children ages 6 to 12 years, so very common. When you hear of the numbers, for example, the numbers of autism have increased over the time my lab and other labs have studied ADHD. They are now as high as 1%. That is, 1 in 100 children have autism. As you can tell, with ADHD, it's about 10 times that. What I didn't know before I studied, my lab studied ADHD, is that there are really many associated disorders. Associated disorders include oppositional defiant disorder, include conduct disorder, and then in teenagers and adults, something that was called addiction in the olden days, and the name has changed now to substance use disorders, or SUD. And why am I interested in this? Because there is evidence for a genetic basis of ADHD, which I will tell you about, and that comes both from family studies with ADHD, and it comes from twin and adoption studies. So just to very briefly, and I will not stay too long on this here, so there's an inattentive type of ADHD, there's an hyperactive impulsive type of ADHD, but the diagnosis altogether is called ADHD, or Attention Deficit Hyperactivity Disorder. So in order for an inattentive type, there have to be issues with inattention, such as careless errors, is inattentive to details, sustains attention poorly, appears not to be listening, sometimes difficult for those of you who have teenagers when they don't want to listen, follow-throughs poorly with an obligation, with homework, disorganized, dislikes or avoids sustained mental effort, and at the same token, or the other side of that coin is, can sit at a computer game for hours at end. So sometimes people say, my child can't have ADHD, he can play this computer game for 2 hours. that's really a hyper-focus and can be definitely part of ADHD. Loses needed objects, easily distracted, forgetful. So if any of you feels you just lost your key today, I had forgotten my PowerPoint presentation when I came here. Do I think I have ADHD? Whether I do or not is a different story, but you have to have at least 6 out of the 9 symptoms that are listed here. So. Same thing with ADHD, the hyperactive, impulsive type, fidgets and squirms, can stay seated. That's, of course, more in school-age children, restless, loud, noisy, on the go, talks excessively, blurts out answers when not asked, can't wait, has a hard time for the teacher to pick on this or that student, and is impatient and sometimes intrusive. And by doing that, sometimes has difficulties in relationships and friendships with other kids. So as I said before, if you feel you have this, that, or the other symptom, that's all fine. That does not make the diagnosis. Of course, as you heard beforehand, what tests are there? There is not like a glucose test where you know, my fasting glucose is 225, that's clearly way too high, or my blood pressure is this or that, and that is too low. The diagnosis of ADHD is really made by observation, and in an ideal world, it's by observation in different settings. So it's observation by parents, observation, if this is the school-age child, in the school, by observations of the child, him or herself. And the definition of ADHD really comes in when there's clear impairment. So that someone who would rank the same high, would have, let's say, 8 out of 9 symptoms on the hyperactive scale, if that person is not impaired by that, because the environment is such, by being outdoors, by being I will not give you any specific professions here, because that could be considered discriminatory, but there has to be clear impairment there. And so some of these symptoms of impairment has to be caused by 12 years of age, and they have to be present at least one other setting and not accounted for by another condition. So just to give you an idea, actually, I think I'll do this here. Just to give you an idea that when this was first described, there is a British physician, Dr. George Still, who described ADHD symptoms just about 110, 115 years ago. And then the first time that stimulant medication was described was in 1937, and then really methylphenidate, MPH, was created in Switzerland in a pharmaceutical company by a chemist who tried every new drug that he did, tried it on his wife, actually, believe it or not. That would be considered unethical nowadays, but that was in the 50s in Switzerland before IRBs. And most of you probably know this. His wife's name was Rita, and the medication that worked the best that he gave her, because she was a well-to-do lady and she had tennis lessons and she always would beat her opponents, and she told her husband, get me more of what you just made the other day. And so his wife, he called her Rita Lee. That was sort of the kind form for Rita, and that's where the name Ritalin comes from. So just in case you didn't know, it's named after his wife. Then there are the definitions of ADHD have morphed over time, and as you can tell, there are some of the findings, such as minimal brain dysfunctions, are quite derogatory. There are other equally derogatory names there, and eventually in the 1980s this has been changed first to ADD or ADHD, and then with the DSM-V in 1987 it was called ADHD. So what we're talking about, what Phil Shaw and I are talking about, is ADHD. So I still remember in the early 90s when I talked in Germany about ADHD, they said, that's an American disease. We don't have it here. Anyone who had ADHD, they would emigrate to the US. So, and here people say, oh, they all go to California. Of course, that's not the case. But ADHD has been around for a very long time. Even Hippocrates, some 2,500 years ago, described patients with quickened responses to sensory experiences, less tenaciousness, because the soul moves on quickly. and then he had some proposed etiology and also treatment. Whether that works or not is a different story. Coming from Germany with a heavy German accent, I'd at least have to tell you about Dr. Heinrich Hoffmann's story, a German, actually not a pediatrician, a general physician who described a book for children. He had children and he was sick and tired of these stories where every child was sweetly either dressed in blue or in pink and everyone was well behaved. So he had what I call the Bible, or whatever your religious affiliation is, for the child psychiatrist. And in this book, Der Struwwelpeter or Slovenly Peter, you find every single childhood disorder that there is. From a child who plays with fire, and this being a German book, of course, the child lights up on fire and burns down to ashes. Or the child that sucks his thumb, and the treatment of that is, oh, just cut the thumb off. So you wonder why people in Germany, why not everyone needs therapy, but maybe they do. So what I wanted to tell you about is really the story of Fidgety Philip. It's one of the stories in there. Sorry, Philip. I wanted to change it, but that was the name that was given beforehand. The reason I wanted to show this to you, this is a story that was, in case you didn't know this, our own Mark Twain spoke German fluently. So when he traveled in the 1850s in Germany, he saw this. And as a German schoolboy raised with this book here, which is pretty terrible, I can tell you, and the rhymes are lousy, when you read Mark Twain's translation, it's beautiful. So you want to read it. It's really good. Just Google Slovenly Peter, and you have all the stories there. So this is an upper-middle-class German family, and I wanted to just make 2 points here, but I won't read all of this to you. There's a mother, father, and a child, and you can see the child has some issues sitting still at the table, and the rhymes I won't go through right now, and you can imagine what happens next is, in essence, the nice family dinner is over with, and you can tell Dad and Mama pretty upset there. Probably not a good thing for their marriage either. The point that I wanted to make is, in Germany, it's not common. Maybe in France you have red wine at dinner here, but in Germany that's not common. So I may venture to say that the father may have some issues with alcohol here. And then the other part is the way the dad holds the knife, that's not how you were taught in Germany to eat with knives and forks. So the dad may have some anger management issues as well. Just wanted to point that out with regards to the genetics of ADHD. So and then next comes, and I didn't tell this, Fidgety Phil has ranks 8 out of 9 on the hyperactive scale if you read point by point, if you go according to the DSM-V scale now. So the story of Johnny Head in Air, just by the name already, you can tell what Johnny has. He walks around and then bumps into the dog here. You can tell the point that I wanted to make here is probably no dog in his right mind would bump into a boy doing this. So I would venture to say that the dog has ADHD as well. And even though I won't go into this here today, is we found that I will tell you about genes that contribute to ADHD. We found that genes that contribute to ADHD, that some of those are actually the ancestral form, so that our ancestors would have the gene that contributes to ADHD, and those who don't have ADHD are the quote-unquote mutants. So the people with ADHD would be quote-unquote the typically developing people, whereas of course nowadays we see this slightly differently since we grew up in a separate environment. And so here the other point I wanted to make, fortunately in contrast to any of the other stories where the kids just die, this boy is saved, but sometimes it goes together, ADHD, with impairment, with lost homework. As you can see here, his homework is floating away. So sorry for this very long-winded introduction. I hope I got your attention to what ADHD is, what causes ADHD, and of course the short answer is it's the environment and genetics that causes ADHD. And I would venture to say that it isn't just the environment that causes the ADHD and not just the genetics, but that there is also an interaction between the genetics and the environment here. Of course, you all know of twin and adoption studies, and in twin and adoption studies, or in twin studies, the interesting part is twins come in 2 ways. They either come in monozygotic twins, where 100% of the genes are the same, And if they're raised together, then of course 100% of the environment is the same. If you have dizygotic twins, what that means is there were two babies at the same time in the same womb of the mom, but they have only 50% of the genes in common. That's just like siblings as they are that are not born at the same time to the same couple, but they would have the same home environment. And yes, we are a combination of our genes and our environment, and these twin studies are shown here, and this is what tells us about heritability. And it's something, if you take something away from this lecture, I wanted you to take away there's some genetics to ADHD, and we can study the genetics of it. What you see here is, and if you feel like, boy, this is late in the day, take a real deep breath. I'll guide you through this, and in 1 minute or in 2 minutes, you will understand this, and you can tell your significant other when you go home. I learned that 70% of genetics is contributed by genetic. 70% of the causes comes from genes, and 30% comes from the environment. So the way it works is when you look at each of these double bars here, the blue and the orange, is one individual study, and all of these studies were done over a period of plus minus 20 years. Some were done in the US, some were done in other countries. It's using different criteria, and the blue bars are those where monozygotic twins were studied that had 100% of the genetic material in common. So if one twin had ADHD, then if you have 100 of those, how many of the other twins has ADHD? And even though the number is slightly different, it's anywhere between 70 and 75%. So that if you have 100 twin pairs where one twin has ADHD, then out of the other twins, about 70 will have ADHD. So what that is telling us is if it were all genetics, if it were 100% genetics, then of course you would have 100 twins who would have genetics, who would have ADHD, but what we have is only about 70. And then when you look at dizygotic twins, so these would be siblings here, where you see that if one twin has ADHD, then about out of the 100 twins where one twin has ADHD, then it's only 25 of the other twins have ADHD. So what that is telling us, it's telling us two things. It's telling us that the heritability is more than 70%, so the genetics of it is 70% and a little bit more, and the environment is anywhere between 25 to 30%. And what it also is telling us, if in a family there's one sibling with ADHD, there's a 25% chance that the next sibling will have ADHD as well. I think just to show you where ADHD is here, so ADHD is anywhere, I mentioned, between 60, 70, and 80% here. And when you compare this, or here it says 80%, when you compare this to other factors where genetics contributes to, only height has a higher heritability. Schizophrenia has a little bit less heritability, and then asthma or breast cancer, where everyone thinks it's 100% genetics, comes up only up to about 30% of genetics and 70% environment. I think I'll skip this slide here and wanted to just tell you about the clinical determination of ADHD. I mentioned already there are different subtypes, the inattentive, hyperactive, impulsive type. Then there are comorbidities such as oppositional defiant disorder, conduct disorder, the various dependencies there. And when we were thinking about this, we were actually had learned from others who had studied this, many colleagues, psychologists, psychiatrists, who felt it's not just the yes or no is important, but what is really important, it's important how severe it is. And that is the severity of each individual symptom. And that then leads to what's called ADHD comorbid clusters, just to show you what that looks like. So when you look here, for example, this is a scale on your y-axis here. It means 1, if it's at 1, the symptom would be very severe. If it's at 0, you don't have it at all. So if you look at, for example, and I can tell you, this scale of questionnaires, everyone and anyone in this room would fit onto this scale somewhere. It's not like it's them out there, these people that have ADHD, and we have nothing to do with it. All of us would fit onto this scale somewhere. And so, for example, if there are people who don't have symptoms, each tick mark that you see here is one of the questionnaires for ADHD. Actually, I realize I can walk around with this here. So each of these tick marks means there's an impulsive quality to it, and either it's a little or it's high. And sorry for the ones on that side here. But so, for example, this blue line here, that would be some people, who have no problems with inattention, no problems with hyperactivity, not oppositional defiant disorder, conduct disorder, don't drink, don't smoke. In my lab, people call them the boringly normal here. So then there are others there who have a little bit here, have a little bit more here, and each of those clusters has different severities. And when you look at it, you can see here there are other clusters there where individuals, for example, in yellow have the inattentive type and not so much the hyperactive type, and then there are individuals who have the combined type, as you see here. And then, of course, you find individuals who are quite seriously affected, and so many of those individuals would be clearly impaired, or they would feel, what I have, it impairs my daily working. And so there's different ways of looking at this. You can, of course, first determine, is there a heritability factor to it? And I hope with the studies that I quoted, I could convince you, yes, there is a heritability factor to it. Then some people, and that is a little bit out of fashion now, have done candidate gene studies where there's one particularly good gene that makes perfect sense in studying this. And then, of course, what people have done, both in our institute, Philip Shaw's group and my group have done genome-wide scans, and then the studies that people have done, they have compared SIB pairs where the sibling who has ADHD, another sibling who doesn't have ADHD. You can do large family studies, and then you can look at very large studies called association studies, where you look at 1,000 people who have ADHD and 1,000 people who don't have ADHD. And my lab and Phil's lab have been involved in any of those 3 studies. So just here, a genetic approach that has proven to be successful, which is an approach where you either look at small pedigrees with 2 affected siblings or at large pedigrees where there are multiple individuals affected. And you can tell this would be difficult here if both mom and dad have ADHD. They could have ADHD for different reasons. So this would be called bilineality. And in our genetic studies, in our initial genetic studies, we would exclude that because it really confuses the issue, because you not necessarily will find the gene that contributes to ADHD in this family. So by looking at both approaches, there are disadvantages. That means in each of those small families, there could be heterogeneity, and that means there could be a different cause for ADHD there. And then what that requires, it requires large samples. And then what we felt, we wanted to study large pedigrees in a genetic isolate. So this would be the Finnish, this would be people, the Icelandic people, who have been for, if not thousands of years, but for hundreds of years, always been marrying amongst themselves. And we tried to find a genetic isolate, and that was not easy to do. And then there is bilineality, a problem which is a disadvantage. And here come the advantages. You have a high statistical power if you have many of those families. And then even if you don't have homogeneity, that means only one gene is responsible for ADHD in this family. It could be 2 genes are responsible, but it's certainly not 20 or 30 genes that are responsible for ADHD in one family. And within one family, you can already find the pattern of segregation, and that is how is ADHD inherited. And you can do that from large families. In small families, that's actually quite hard to do. So we have combined both and used that to identify ADHD genes, which I will tell you and give you one example over the next short time. Just to tell you about a genetic isolate, everyone knows where Columbia is. It's not a university in New York City. It's a country in South America here. And here's a larger view of this part. And these are the Andes Mountains here. And there are the Western Andes, Central Andes, and the Eastern Andes. And between the Western and Central Andes, there's a region called Antioquia with the capital of Medellin, which probably you know for a different reason. And that is where we found a genetic isolate and studied a genetic isolate with many affected individuals with ADHD. So in the rest of Colombia, ADHD is as common as in the rest of the world, about 10%. In the Antioquia area, about 5 million people there, ADHD is 20% and actually up to a little higher than that. So this is what a typical family looks like. And in my laboratory, we have had quite a number of so they call themselves the paisas, who live in Antioquia. We have, looks like some people are smiling here because you might be paisas yourself here. Don't look at anyone. So I've had a number of paisas in my lab. MD PhDs, I'll point out to a few of them who have done the work here. And you find that there are, for example, individuals who have ADHD, some are possibly affected, some have conduct disorder, oppositional defiant disorder, and some have alcohol dependence, nicotine dependence. So this is a real pedigree from a real family. I had a postdoc here, I said, how often do you see each other as a family? And he said, twice a year, once for Christmas, and then the second time when someone turns another decade, and with 11 or 12 siblings, every year, one sibling turns 10, and the other one turns 20, and the next year it's someone else. So, making a long story and a genome-wide analysis short that was done here at our institute, we found a number of significant linked loci that we found in these families that we found in the paisas here. I will focus only on one of them, and that is a region on chromosome 4, where we identified a gene called latrophilin 3. And there are two things that I would like you to take away with it, and that is latrophilin 3 is what's called a G-protein coupled receptor, and of course most of you will know what a receptor is. A receptor is a molecule, this molecule here, that goes from the outside of the cell, so there's an extracellular part, and then there is a transmembrane domain part here, 7 transmembrane domains here, and then there's an intracellular part, and that is very important for moving forward a signal from the outside of the cell to the inside of the cell. And that is what latrophilin 3 does. So we did a number of studies with, I call it for short, LPHN3, and without guiding you through every single minutia of the brain scans here, I just wanted to point out of what we did in this study here. So what we did, there's a particular brain scan called proton magnetic resonance spectroscopy, long word, and what that does, it provides an index of the number of cells and the metabolism or viability of these cells. And what has been known, there's a specific ratio that I have practiced so many times, but I won't say it right now here, that is decreased in individuals with ADHD. And what we felt we wanted to see in the paisas, where we had studied individuals who had one form of this latrophilin 3 gene, what we called the susceptibility gene, versus the other form, which we call the protective gene. And we studied, here as you can tell, 15 individuals who had at least one copy of the susceptibility gene. Then we studied 10 individuals with at least one copy of the protective gene. And then we studied 8 individuals who had different haplotypes. And so what we find is, we find that there is a clear-cut difference between individuals who are either controls or who have 2 copies of the protective gene compared to individuals who have 2 copies of the susceptibility gene. And what we find that this specific metabolic brain ratio of N-acetyl aspartate to creatinine ratio, which has been decreased in individuals with ADHD is also decreased in individuals that we had studied when we looked at the brain scans. And moreover, we find that individuals who have 2 copies of the susceptibility gene actually have the metabolic changes in the brain going on that correlate with the gene. So what this is really telling us that we have our genetic studies show us that the susceptibility allele of this gene, that goes together with the metabolic changes that happen in individuals with ADHD. And so and then I have another 2 minutes. Actually, if you can give me 3, Philip, I would appreciate. Good, thank you. So what can we do with this here now with regards to medication? Can this tell us anything? And the short answer is, in the future it will. At this very point, we have only some glimpse of it. Wanted to just tell you what the CDC in Atlanta found in a study that was done in 2010. It's reported that children, that when you look at the different age groups here, 4 to 10, 11 to 14, and 15 to 17, these red bars show how many children have ADHD, and then the gray bars next to it are the bars of children who are on medication. So it's not quite as high as you heard in the prep school in New York City, where up to 40% of children are on ADHD medication. But if you look at all children in the US, the thought that out of 11 to 14-year-olds, over 6% are on ADHD medication. That to me is a huge number, a huge number. And so just wanted to show you a study that we did by looking at individuals, at children, where we both had the genetic underlying basis and where we found out from the parents, how are your children doing when they're on medication? And then some children go off medication. Usually the off medication time is during summer break, is during winter break, and so on. So what you find on the left side, you find children who are off medication, and here the quote-unquote typical range would be around 0, and you find that there are different patterns there where individuals are very high on the ADHD score here, and then those children do get medication, and you find that those children, or some of them, do much, much better. So for example, you see children who fall into the category with a purple line here, once they are on medication, they have barely any symptoms, they're actually doing pretty well. So these are the children who respond extremely well to medication. And then you see children who are not doing well at all on medication, off medication, they get medication, and they don't do well at all either. And so what that is showing, it correlates to the studies that have been around for quite a while, that up to 1/3 of children who are on ADHD medication do not respond well to medication at all. They may have even more side effects than positive effects of it. And wouldn't it be wonderful if instead of going from trying one medication out for 3 months, then another medication for 3 months, the kid gets frustrated, the teachers get frustrated, the parents get frustrated, if we could just do a genetic test and we would know you respond to this medication. You respond by playing soccer for 2 hours every day. You respond to do mindfulness-based stress reduction, and so on. There are lots and lots. You respond to various kinds of diets, if there is such a thing, if that would work. So what we did was, make a long story short, we looked at the LPHN3 susceptibility gene, and we found that we can predict that we have a significant p-value for the prediction of telling who will respond to medication, who will not respond to medication. And even though these are just baby steps, what I hope is in the right direction, I think it's showing that based on looking at the medication that a child takes and the genotype that a child has, that this actually will eventually allow us to do personalized medicine for every child specifically. And I think the last thing I'll have to show you is, I'll spare you, this paper is listed here, I just have to show you about work that we did in the zebrafish, where we have down-regulated the gene for LPHN3 and looked at every single zebrafish who either has the down-regulated gene or has the normal function of the gene. And even though it's hard to see, I can tell you when we did this here, we study every single zebrafish here, and we take a picture, 1,000 pictures per second. So every millisecond, we look at every zebrafish who is either down-regulated for latrophilin 3 or who has the normal latrophilin 3. And I can tell you those who have, those zebrafish who have the down-regulated latrophilin 3 are the ones who are hyperactive. It was a little hard to determine inattention in the zebrafish. So, but with the hyperactivity, we could show that, yes, there is a correlation there. And with that, I say thank you very much and show you those individuals who have done the work. And the person, the two main people who are, sad to say, not here anymore, but both at the university, at the Australian National University in Canberra, is Mauricio Arcos Burgos, Jorge Ivan Velez, both from Colombia, and then individuals who are studying ADHD in the lab right now is Ariel Martinez here, Maria Acosta, many other individuals who are studying this as well. So thank you for your attention. And if I'm not mistaken, maybe it's best to do questions at the end. I repeat your question, is anything known about the down-regulating signaling pathway? And the short answer is, believe it or not, no, very, very little. So if there's an LPHN3, you know there must be a 1 and 2. Those have been studied in quite length and detail. LPHN3 is one of those under-studied genes at this point, actually, so hard to believe. Has a very similar structure, I forgot to mention that, has a very similar structure to other genes that have been shown to be involved in ADHD, such as dopamine receptor genes. Very similar. These are also G protein coupled receptors.
So do people outgrow ADHD? Do you just cope with it? So how's that work?
That is a wonderful question. I can give you my 2 cents at it, and then Phil will give you much more sophisticated answer to that. So what happens is people, as they get older, the brain matures, and also as people get older, they learn compensatory mechanisms that work well for them. And the better they can learn those, the better they can deal. And that's why there are plenty of colleagues at NIH who have ADHD, and you meet them and you know, yep, you have ADHD and you're doing extremely well with it. Of course, a high IQ is a benefit. So with that, there's lots of learning and as you get older. And Philip will tell you in more detail why some children, I think our first glimpses at why some children, quote unquote, seem to outgrow ADHD and seem to be doing quite well as adults, and other children less outgrow it and don't do so well as adults.
Tell us about the cost of medication.
The cost of medication, frankly, I don't know even the price. I know what it is on the black market. You know, you may know that Ritalin and the various stimulants medication are the second most common drug used in college. Actually, I won't even go there. That would be politically incorrect. Second most common used drug at campuses, college campuses. One of the tablets goes anywhere between $5 and $10, and it helps people study for their exams, and they do better. Of course, one question that you didn't ask, but I'm burning to tell you, is that if you take the medication and you do better, does that mean you have ADHD? No, it doesn't mean that. It just means it's a stimulant medication. It's like a cup of coffee. And if you target it just right, if you just have just the right amount of caffeine, you will do quite well. So anyone benefits from it. So.
Do you think that taking Ritalin is analogous to a cup of coffee? Is that what you're suggesting?
I understand from some people anecdotally that some people with a cup of coffee, people with ADHD do better with a cup of coffee than without a cup of coffee. So caffeine is obviously a stimulant, and so is ADHD medication.
Have there been other large families like the Medellin family that have been studied? And if so, do they turn up other genes?
Even the Medellin families turn up other genes. One is called neurocell adhesion molecule, and we have others there. And Philip Shaw is actually studying large families here at NIH, but I don't want to steal his thunder.
You think this gene is actually increasing in its frequency because of some positive selection, that it's actually doing something good for the population? Mm-hmm. And that's why we see this increase? Or is it just the way society and behavior is these days that's bringing this out?
So this is a very hot topic, and we could talk about that for the next hour and a half, of course. Why do we have more children with ADHD now? And or is this society, by going to school, and if someone has set his mind, my daughter has to go to Harvard, but never mind, in first grade, she looks out of the window instead of at the blackboard. I think that is certainly one of the issues. What seems clear is it based on our studies, when we look at our relatives of higher primates, they all of the primates that we could get DNA samples from have what we would consider the susceptibility form of the latrophilin gene. So again, us humans, the ones who don't have the susceptibility form, would actually be what I would call half-jokingly the mutants. There were in earlier times, there were individuals there who had more of the susceptibility form, so, if that makes any sense.
So is ADHD a disease of a more economically developed society? Do you find it in deepest Africa, and does it correlate in any way with poverty and affluence?
Mm-hmm. So the short answer is I don't know. The longer answer is a little bit more sophisticated than that. In those countries where studies were done, there are no differences, as far as I can tell, with regards to economic levels, not with socioeconomic levels. And it seems to be really something more cultural. And I know I have to close, but I'll tell you one brief story. A colleague of mine from Japan was for a 3-year postdoc in Seattle with his wife and his two boys, and they loved the US, they loved Seattle, they loved the kindergarten. They came back to Japan, and something truly unusual happened that never ever happens in Japanese schools. The parents were called in for a teacher-parent conference in the middle of the year. It's like it just doesn't happen. And they were told that their children were severely behaviorally disturbed, and the reason was they would behave like American kids in the kindergarten. They would not sit still. It was not culturally accepted in Japan to jump over tables, which was like personal freedom in this country, at least in the kindergarten. So it's, I think cultural norms do a lot to this. Yes. So with this, I say thank you very much and look forward to Philip's talk.
There'll be time for more questions for Max at the end. So think of anything you wish to discuss.
Okay, yeah, thank you.
Oh. That's clever. Cool. And then, I'll let you do it. Uh-huh. Okay. And then do I do the hit the slide thing? Yeah, cool. Great, thank you. Cool. Hi, hello. Hi. First of all, thanks, Frank. That was great. It's a pleasure to be here, and thank you very much for the very kind invitation. So my name's Philip. I've got a dreadful cough, so I apologise in advance. I'll be coughing throughout. I've just been to Ireland, where I think I managed to pick up every known bacterial infection known to man. There you go. I'm going to kill all my young relatives. So I thought I'd start off by, we don't have a young child with ADHD with us here today, I think for obvious reasons, because I can tell you what would happen. It's because it happens to us a lot, because we do clinics every Friday in the clinical centre in the paediatrics room. And if we had a kid with good going ADHD in this room, within minutes the child's head would be lodged in the space of the chair there, their feet would be flailing around. They would then promptly get up and try to find the power sockets to sort of stick their fingers in them. And it would just be a little bit chaotic and a little bit overwhelming for a young child. So instead, I thought I'd just describe two of the children in our study. So one of the little kids in our study is called Peter. And Peter was brought to the clinic by his extremely exhausted-looking mother, who just said, you know, this child really has been doing somersaults in the womb and he has never stopped. This child is exhausting. At age 3, she was called by the sort of pre-K, who just said, we can't cope with this child. You know, even in pre-K, there's some minimal requirements of stillness, and this child just could not do them. In reading circle, he'd be up over, climbing up the walls, climbing over furniture, completely unmanageable. This is a kid who, by the age of 6, there's already talk. This is a child with a high IQ. There's already talk of holding him back for a year because he can't complete even the very basics of learning because he is just so hyperactive and so impulsive and cannot pay any attention at all. And this has impacts not only on his learning. Peter, if you go into the classroom, one thing that's very quickly observable is little kids are actually quite cliquish. They have their little friendship networks that they all inhabit. Peter is isolated, and this is not at all uncommon for kids with really severe ADHD. They are often very impulsive children who will get into the physical space of other kids, will pinch and hit to get attention, not with malice, but through impulsivity. That said, your average 5-year-old doesn't get this, and so will isolate themselves from these kids. So social impairment with peers is another key feature of ADHD. So little Peter has got social isolation, he's struggling with friends, he's doing disastrously at school despite his high IQ, and then you turn to his parents. And you know, the mum was very honest, she said, I love my child, but I'm really not sure if I like him very much. She just couldn't get him to do anything. So we spent a day, the diagnosis of ADHD, certainly in research settings, is very complex. You know, it is not an easy phenotype. So we talk to the parents, we talk to schools, and we meet with the child. The diagnosis is clinical still. It's based on history with those 3 sets of informants. But, you know, we also do lots of psychological testing. And then at the end of the day, the pièce de résistance of our study is to get the child to spit into a little tube so we can get some DNA, which is always fun. And then we ask the child to lie still in a magnetic resonance scanner while we take pictures of their brain. And actually, we've got quite good at this. And little Peter managed to lie still for 25 minutes, after which his mother offered to buy the $1.5 million scanner. Now, Susan is another little girl in our study, very, very similar when you meet her to Peter, hyper. This is Susan, very physically impulsive, particularly noticeable in our society whenever a girl is physically impulsive. Again, very isolated in the classroom, extremely distractible. She really is the sort of child who couldn't complete the simplest of tasks. Her mind just wanders. It's like she's in a perpetual daydream. You talk to this child, you may as well be talking to the wall. I think she hears there's a cloud there that words get into, but they just dissipate very, very quickly. Struggling disastrously at school. Parents are coping very well, terribly laid back, but, you know, they're really concerned about the future. So again, Susan, she's a kid who is struggling with peers, doing very poorly at school. Parents are coping quite well, but there's still impairment there, and she also would meet the diagnostic criteria for ADHD. So what I'm going to talk about a little bit is what's going on in the brain of these children, what do we know of their brains, and then a little bit later I'll consider sort of like what happens to these children as they get older. So the first question is the brain atypical? Is the brain any way different in ADHD? And I think it's a good place to start. And what we started with looking at is, this is quite an old study. It was started by Judy Rappaport and Javier Castellanos back in the 1990s. And it's an ongoing study. And one of the strengths of this, and the strengths of the intramural program, is that it allows this sort of longitudinal study. So a lot of what I'm talking looks at kids who entered the study in the 1990s and have been followed up right to the present day. It gives us a lovely amount of longitudinal data. And if you're trying to look at a developmental process, such as ADHD, longitudinal data is perfect for capturing such developmental processes. So I'll just briefly talk about 3 little studies we've done, maybe just 2. So each of them addresses the question, is the brain in any way atypical in ADHD? And are these anomalies, are these differences fixed? Do they remain throughout the lifespan? Or do they change? Is the difference in the brain in ADHD the difference of a trajectory rather than a difference at just one point in time? So the first study I'll talk about is here. This is the human brain. So here, of course, we're looking at the brain from the side. So all the studies I'm going to talk about today actually use anatomic imaging. So it's structural brain imaging. There are many, many other ways to look at the brain. I will focus on anatomy here. So the actual structure of the brain. We can define this safely in children using magnetic resonance imaging. It doesn't involve any ionizing radiation, so you can safely do it on children year in, year out as they grow up. So here we have, just to orient you, and apologies to anyone, this is super simplistic, but here we have the brain, of course. This is the front bit, cognitive control, higher order centers, planning. Here's your sensory motor strip. So I'll talk a little bit about the cortex later, but what I'm going to focus on, first of all, are these deep structures in the brain. These are the striatum. And the reason they're colored the same color is that projections from the frontal lobes to the striatum and then back out again are quite organized. So different parts of the frontal lobes project to different parts of these deep striatum, the information processing centers of the brain. There's these wonderful information processing loops that all talk to each other, but they go from the frontal lobes to the striatum back out and then to many, many other regions of the brain. So here I'm just going to look at the striatum. So here we go. And if you're like me, I never understood neuroanatomy at medical school at all. Like whenever I got to the final class, they sort of, the first question was, which way round is this brain, Philip? I was like, oh, I can get that one. So here we go. These are some very nice images where we get MRIs, the magnetic resonance imaging, and you go in and you use very sophisticated tools which are developed by colleagues in Canada to extract these deep brain structures. And these are the striatum, the deep information processing centers. So just to orient you, here we're looking at it from the right side. This is called the putamen, and this is the caudate. So we can just flip it around. Here we go. Oh, it's not working. Oh, well, anyway, that's a shame. Anyway, it was good to show you. It was going to spin around and just really show you in 3Ds the deep striatum of the brain. So what we're asking here is many, many people have looked at the striatum in ADHD. It makes an awful lot of sense to look at it in an information processing center if you're thinking about a problem such as ADHD. So lots and lots of cross-sectional studies, and pretty consistently they find that this brain structure is a little bit smaller in kids with ADHD. The difference is not enormous. If you know in terms of effect sizes, it's a small difference, but it's there and it's pretty consistently found. So that's the sort of cross-sectional story. If you take lots of young kids with ADHD, compare them to kids who don't, you pretty consistently will find a little bit of a smaller, at a group level, in the kids with ADHD. Again, I'll stress the overlap is enormous. That's why we can't diagnose ADHD from brain scans. But at a group level, there's a detectable small difference. So we went on to say, well, we have these fantastic images of children as they grow up with ADHD. Is there perhaps more of a difference we can pluck out in how things grow with time? We are, after all, thinking of a developmental disorder. Is it the trajectory of growth that's different rather than difference at just one time point? So we've got 270 kids with ADHD and 270 kids who don't have ADHD, and most of these kids had repeated imaging. And so using statistical methods, you just define the trajectory of growth of the striatum. And we did this for thousands of little surfaces on the striatum. So we used a method just to define the change in surface area throughout these striata. Now, the first thing we did, just to orient you, first thing we said, well, do we find what everyone else found? Is the striatum, if you do a cross-sectional baseline study, is the striatum a bit smaller in ADHD? And indeed it was. So here we're looking at the striatum. These are from the front. This is the front. That's the caudate. This is the putamen. Caudate, caudate, putamen. And this is looking from the bottom. So this is called the ventral striatum here. So anywhere you see colour there, it means that the surface area of that part is reduced, is significantly reduced in kids with ADHD. So this is just a cross-sectional comparison, confirming what I think many people have shown before, perhaps with a higher level of spatial resolution. In terms of the size of this effect, it was small. There's a big overlap, it's a small effect, but it's very robustly significant. Confirms what we knew. So then we went on to say, well, what about growth? So we have these kids sort of interleaved from about the ages of 6 through the age of 18 when this study ended, and we charted the trajectories of growth. So just to orient you, here again we're looking at the striatum, and each graph here just shows surface area change. This is the x-axis, which is age, from age 7 through 17. And the y-axis here is actually the surface area of one tiny little vertex on the striatum. So we just picked out lots of little vertices, just kind of at random. So what you can see by and large is look first at typically developing kids who are in blue. The striatum, most of the surface gets a bit bigger with age. No great surprise there. Many others have shown that. The striata get a bit bigger until you're about 16 and then probably get a bit smaller. But what about the kids with ADHD in red? Well, we know they're a bit smaller at baseline, but would this be fixed? And indeed it was. They have a reduction in surface area, and it was kind of parallel. So there seemed to be largely a fixed reduction here. But then we said, is there anywhere where the striatum developed differently in the kids with ADHD? Is there anywhere where the trajectories had a different path? And indeed there was, and it was only really in one area now, and this is looking at the striatum from the bottom. So this is called the ventral striatum, and it was in this region that you had different diagnostic trajectories. So what happened in that little region there? Well, this is typically developing kids. It got a bit bigger, as it did for the rest of the striatum. But what about the kids with ADHD? They're in red. It actually got a little bit smaller with age. It actually contracted. The surface actually contracted. This is a very interesting region. I'll just skip this movie. I'll just skip that. So it's an interesting region because the ventral striatum is very intimately linked with many, many things that we think might characterize the psychology of kids with ADHD. For example, the processing of reward. So kids with ADHD, as a group, show a marked preference for having a small, immediate reward over a longer one that's delayed. You go up to a kid and you say, I will give you $10 in 10 minutes or $1 now. Which one would you prefer? Lots of typically developing kids will know, well, I'll wait the 10 minutes. Kids with ADHD reasonably reliably will go for the small, immediate reward. This is palpable when you see them in the classroom. Star charts where you say, oh, Toby, if you're good, we'll give you something at the end of the week. You may as well not bother. You've got to do it immediately with these kids. So the processing of rewards is a little bit different in ADHD. That makes a lot of sense for the ventral striatum. It's also a very important region for the processing of affect. And again, there are some affective differences in kids with ADHD. And by no means are all of them negative. A lot of kids with ADHD have a wonderful exuberance and brightness to them. And this might be a sort of a dispositional bias, some temperamental component. Again, something that has been linked with the ventral striatum. So in terms of the psychology of what we know about ADHD, this finding made an awful lot of sense. I'll also point out that if you do functional imaging studies and put kids with ADHD in the scanner and give them tasks which require them to process rewards, this area will be hypoactivated pretty consistently. A nice alignment of structure and function. So now I'll just go back to Peter and Susan. I'll just spend a couple of minutes and then I'll end. So Peter. So what happened to Peter? Well, Peter, as you remember, the kid who lay still in the scanner, so his mum and dad decided, well, we're going to try medication. And Peter was kind of like, he was started on Ritalin, and he was like the poster child of a response to Ritalin. And this often happens. You know, the parents will come in and go, what have you done to our child? And teachers will go, is this the same child? It is, when it works, it is fantastic, and it works in the majority of cases of kids who have severe ADHD. Has to be monitored carefully for side effects, but it is extremely effective when it works. And that was Peter. He did brilliantly with stimulants, and he was able to tolerate them as he grew up. They kept a very close eye on his height and weight, as you really have to. He grew beautifully throughout it all, and he did great. When he got to about the age of 12, 13, his symptoms are waning a little bit, so the parents started to withdraw. It didn't really need it. And then, whenever we recently saw him, at the age of 18, he was doing brilliantly. You know, this child, no symptoms at all of ADHD, just doing brilliantly, about to head off to college, did fantastically. Peter would be a case of full remission of the disorder, which, you know, happens roughly about 30%. What about Susan? Now, Susan at baseline looked identical, well, not identical, which is a girl, but, you know, in terms of her ADHD, looked extremely similar to Peter. You could not tell them apart clinically. So, Susan, however, just, you know, initially the parents were a bit reluctant to try medication, which is fair enough, and then they waited for a little bit and they tried, and actually she didn't respond well to medication, as about 20 to 30% of kids won't to stimulants. And then she was started on all the second and third line medications for ADHD, none of which really suited her. Unfortunately, Susan also didn't really get the other things that can help kids, like behavioral plans at school and educational plans at school. That didn't happen, as is often the case, sadly, and she really struggled. This is a girl who I think had an IQ of about 115, 120, who barely graduated high school. Whenever we last saw her at the age of 16, actually we've seen her since then, she was having a really struggling time. She had still a full house of symptoms of ADHD, extremely hyperactive, impulsive, very inattentive, had one depressive episode and was beginning to misuse substances. I'll have to say that when we last saw her, she was actually doing much better. Her ADHD was still very persistent and the substances had rather waned. But again, Susan would be a case of full persistence. Now, one of the problems with ADHD is whenever I see parents, when anyone sees parents in clinic, and one of the first questions parents will ask is, how will my child do when they're older? I think I can get through the next year or two, but what will they look like whenever they're 16? And you know, it is very, very difficult to predict outcome, because many of the usual suspects of poor outcome in childhood psychiatric problems, and that would be low socioeconomic status, having poor access to health care, having very severe symptoms at baseline, they don't strongly predict outcome in ADHD. It is very hard to predict outcome from the typical usual contributors to a difficult clinical course for a child. So that turns us to other sources of information, and one of which is the brain, and the other of which is genetics. And I'll just talk a little bit about the brain. So in this study, as I said, one of the joys of working here is you can follow people up. So this is the 1970s cohort. There were 200 kids with really severe ADHD in that one. And then we managed to get back at the age of 24, 112 of them, which really isn't bad going at all, given, you know, how mobile populations are. And of those 112, we scanned everyone, and we had this number of good quality scans. You always lose some for quality reasons. So what we're able to do then is we have brain images, the same brain images actually acquired on the same scanner on these individuals as they grew up from childhood to adolescence to adulthood. So what we ask now is, where does the course of your symptoms, where is that tied to the trajectory of your brain growth? The very broad hypothesis was that if you get better, you're going to converge towards typical dimensions. If you get worse or have very persistent symptoms, then you're going to diverge further and further away. So what we looked at, first of all, is the thickness of the cerebral cortex. And this, again, is acquired from the structural images. The thickness is extracted by the computer at sort of 80,000 points throughout both cerebral cortices. And so then what we're doing here is we're asking, Where does the change in the thickness of your cortex, where is it correlated with, or predict, if you like, the ultimate adult outcome of ADHD? And the regions where there was this coupling of trajectory and clinical course are shown here. And as you can see, these are medial views of the brain. This is all one brain template. Here we've split it in half and opened it up. And this region is called the cingulate cortex, posterior cingulate cortex here. Here, the trajectory of how that cortex changed was very strongly associated with, or predicted, if you like, how many symptoms you had as an adult of ADHD, particularly of inattention. I'll note that there was absolutely no relationship at all with hyperactive impulsive symptoms. That wasn't predicted, which was against what we hypothesized, but hey, you know, half of it was okay. So there we go. So what's happening in these regions? I'll just skip that. I'll just show you this graph, which will show you what it is, and then I'll probably end there. So here we go. This is age, and this is how thick the cortex was in that region. So blue are typically developing adults, young adolescents, adults, and the cortex gets a bit thinner in that region, and that's been known for many years. The cortex gets thinner during adolescence. And what about the kids with ADHD who got a bit better? Well, they start off a bit thinner, and then they converge towards more typical dimensions. And what about the kids who didn't improve with ADHD? They're the ones shown in red here. They essentially, we predicted that they would diverge. They didn't actually. This is a non-significant difference. It was more of a fixed difference with age. So really just to think about those regions, again, in terms of the cognitive science of ADHD, a lot of those regions make sense. They are regions that are very much involved in the control of attention. There are also regions that are intimately linked with something called the default mode network of the brain. This is sort of like, you know, whenever you're doing nothing, when your mind is wandering, your brain seems to have quite a stereotypical response. It just lapses into this sort of anti-activity, which is spread over different regions of the brain. And actually, one of the structural differences here lapsed into that. This is interesting because one hypothesis of ADHD is that it's due to this default mode network, or mind wandering, intruding whenever it shouldn't. And that presents itself as momentary lapses of attention. Very hypothetical, but I think a very interesting hypothesis, not mine. Okay. And also, the other thing I think to note is that the picture begins to emerge of the brain, and we all know it's richly interconnected. And in previous work, we had found, for example, that the trajectories of how the frontal cortex grows were also altered in kids with ADHD. They were both a bit slower and in some ways a bit delayed in very focal regions. So there was a very stereotyped change to a trajectory in the frontal cortex, and then also a change to the trajectory in the striatum, which receives lots of impulse from these frontal regions. So the picture begins to emerge of ADHD as perhaps part of the story being a disruption to the development of coordinated brain systems. And I think, actually, I'll just skip all of those bits, and I'll just end with that. Like, you know, this is all very good, but what can we do with it? And I'll stress at the minute, there is still no clinical role for MRI or brain imaging in ADHD. It remains a clinical diagnosis. Will that be the case in the future? We certainly hope not. I think the aim is that by combining different modalities to look at the brain, we will actually get to a signal which can help at least shift the probabilities that this child has ADHD. Perhaps even more ambitiously, can we use this sort of information to predict future outcome? So this hypothesis, you know, this information is all purely observational and descriptive. So now what we're doing is we're taking this description and we're seeing if we define these trajectories of growth in young kids at 3 time points 1 year apart, will that predict later clinical outcome? So we're taking the great observations that are allowed by this longitudinal study to do a sort of much more accelerated, can we find some sort of neuroimaging marker which can at least partially inform the probability of the clinical course of a child so that we can better inform parents whenever we meet them in clinic as to what they might expect for the future. And on that note, I'll end. Thank you. So the question was, are there gender differences in the rates of diagnosis and in response to medication? And there are. So ADHD, like a lot of neurodevelopmental problems, particularly externalizing ones, which you can see, they're ones of behavior and regulation of emotion and behavior, is more common in boys. People argue about the exact proportion. I think the best estimates is about 2 to 3 times as common in boys as it is in girls. I don't think that's diagnostic bias. I think that really is just how it is. Is there any difference in how people respond to treatment? Not as far as I know. I think people will just respond to treatment quite well.
Thank you. Is there any, well, it's loud now. Is there any correlation between response to treatment and the likelihood of them having a remission later in life? And so and also being treated and possibly their cortical thickness later in life, whether they receive treatment or they don't receive treatment.
Yeah, so, no, it is very, hand on heart, it is very difficult to show that stimulants, if you take them for 2 years, how long will they work? So there is one extremely good trial called the MTA, Multimodal Treatment of ADHD, which managed to do a double-blind trial up until the 18 months, which is a phenomenal achievement. And it showed, without doubt, up to 18 months, stimulants are very, very effective. They were really very effective, had an excellent safety profile and extremely effective up to 18 months. After that, we rely on observational data, and that's really complex to interpret. If you think about it, kids with stimulants who have very severe symptoms might end up being the very ones who need more and more medication. So it's hard to make the link with observation. Clinically, we think by giving stimulants to kids, we give them the opportunity to succeed each day at school if it's safely monitored. That, in turn, should lead to experience of success rather than failure, which we hope impacts long-term outcomes.
So Mac told us that Ritalin was discovered by serendipity, right? Because a chemist was trying to do something with his wife. At any rate, so it turns out that it's a stimulant. And yet you describe these children, if anything, as being hyperstimulated. I don't understand that. So what is your thinking about what the mechanism is as to what's going on? I mean, a priori, you would think something that would slow them down would be better. What's the basis? What do you think in a neurophysiologic cellular basis? What's the concept as to what's going on? Oh, you want to answer?
Yeah. My question sort of relates. Could you also comment on the benefit of sports and athletics for treatment?
Okay. So in terms of the theories of how psychostimulants work, they alter dopaminergic tone, and it is thought that they mainly alter dopaminergic tone in the deep striatal areas, which then has a feed sort of forward effect to the frontal cortex. They do it by slightly different routes. There are 2 big classes of stimulants. There's the Ritalin-like ones and the amphetamine-like ones. The Ritalin-like ones stop dopamine being sucked up back into the presynaptic cleft. The other ones, the amphetamine ones, flood the system with dopamine. And I think there's very good evidence that does happen. Why that makes children much more focused, I think one intuitively appealing way of looking at it is that if you are in a hypodopaminergic state, then you are sort of creating stimulation around you. If you correct that deficit even temporarily, then it allows you to sort of be much more engaged in a typical fashion with your environment. That's purely hypothesis, but that's one idea. The other very nice way of thinking of it is that fantastic inverted U, of arousal, and where are you, and where are kids with ADHD, and if stimulants tip them one way or the other way. So those would be the 2 ways of doing it. Sports for kids, like diet for children, I think a good amount of sport, particularly to children who enjoy it, and a healthy diet for all children are just important for all children, regardless of whether they have ADHD or not.
Is it true that half of professional football players have ADHD?
Well, it's certainly true that an awful lot of very successful people have ADHD. Certainly, if you think about the genes are very common, so in some ways, particularly if you outgrow ADHD, I wonder if some of the inattentive styles that are left behind might sometimes have some sort of adaptive role. And certainly, there is no reason to be too pessimistic. I know of lots of incredibly highly achieving people who are still on stimulants.
I was just wondering if the MRI studies had placebo controls. Did the controls have placebo? Were they taking pills that they didn't know were one thing or another?
So the studies I did are purely structural. So they were open observational. There are studies that have been done, and I think probably a better way of looking at the effects of medication, I think, are brain functional studies. And there's a very lovely series of studies by Katia Rubea and others, which did double-blinded administration of a stimulant or a placebo, and then looked at the effect on brain activation during cognitive probes, which tap domains that you think would be problematic in ADHD. Pretty consistently, her work has shown that the stimulants temporarily, and it is only temporarily, rectify some of the underactivation of some of these brain areas in kids.
Which were the brain areas?
It depends on the task. That's what's so interesting about it. Certainly the striatum, certainly frontal regions, but also she showed some normalization, or sort of near normalization, of temporal lobe activity. If the cognitive task requires that region, then it requires that region.
So was the ventral striatum always indicated?
No, that's a really good. I don't think anyone's done the reward processing on and off stimulants. That would be an interesting study to do, actually. That I don't know of. I know that lots of cognitive, more classically cognitive probes have been done.
My question is it possible for these drugs could structurally help the brain to maybe get back to the original trajectory or have normal treatment?
Yeah, again, the only way to really answer that would be to do imaging within the context of a blinded trial, which has never been done for brain structure, just because it's such an implausible thing. Certainly, there are now 6 or 7 good studies which have looked at children with ADHD on and off medication and compared them to typically developing children who have neither ADHD nor medication. The biggest difference is between having ADHD and not having ADHD. If there is a difference with medication, there's a hint that the kids on medication have less atypical volumes. You have to be incredibly cautious interpreting that. You have to know, why were those kids on less medication anyway or not on medication? So my take from all of it is there certainly isn't an alarming bad association with psychostimulant in terms of brain structure. Would it rectify structure? I don't know. Would I expect it to? I probably wouldn't, actually. I would expect it to temporarily improve brain function. And then once it's out its system, remember, these medications only last for about 6 or 7 hours. Then the brain goes back to how it typically functions. And that's kind of the main story that's coming through.
I don't know, this is in a way, a politically hot topic. The question is, if there's 10% of expectation, 10% have ADHD, then what is the percentage of kids in the American school system that are getting Ritalin for presumed ADHD?
Yeah, I'm actually the 2010 figures, but yeah, that was, yeah.
I mean, the 2010 figures is about 6% of children. 6% of children are on medication. So this is not all children are on medication, but what, of course, I wanted to go along your politically hot topic here is, would it be that some children who don't have ADHD are on medication versus others who have ADHD would benefit from ADHD medication and are not on medication? So I think what Philip was talking about, it's very important to make the diagnosis so that if a child has ADHD and would benefit from being on medication, that would be wonderful. And it's a loss for that child of not being on medication or on the proper treatment accordingly. So. So the numbers currently are that we have more children with ADHD and less children that are being medicated. So 6% are being medicated versus 10% of ADHD. So even though probably most people think otherwise.
Okay.
Hi. How common is it for an adult to be diagnosed with ADHD? And do you ever see the hyperactivity associated with it? Or is it mostly like the inattentiveness? Or I don't know.
So the reason that worldwide, there's a very nice meta-analysis, it's about 2%, 1 to 2%, which kind of goes along with the, the remission rates, which we said. And inattention is much, much more common. So hyperactivity, but maybe that's because, traditionally, ADHD was thought of as a childhood problem. So the diagnostic criteria are based on the observation of children. The criteria have been adapted a little bit more recently in DSM-V to make some examples that are more applicable to adults. I think Max mentioned the very good one, restlessness, for example. For adults, that's the person who has a subjective sense of inner torture whenever they have to sit still. Most adults, although some do, most adults do not climb over chairs. They will manage to sit, but it will be torture and they'll be fidgeting and squidgeting. So it's perhaps a different expression. Is it impairing? Often not. It really mostly is the inattention and the impulsivity.
Hi. Do you think that there are any cultural differences amongst the patients that are diagnosed with ADHD? So, for example, say if a parent is having a lot of trouble with their child and they simply think that the child needs more discipline as opposed to it's an issue where we need to see a physician, or say if they go to a school where the teachers they don't communicate the issues with the parents as often as if they went to a school, where they have a lot of communication or they really hear more, quote unquote.
That's the importance of a good clinical training and assessment, because basically if you do it properly, you'd have to be a very unlucky kid to have the world's worst parents as informants, the world's worst teachers as informants, and then meet the child and they're perfectly good. If that does happen, and sometimes does, it raises your eyebrows. What you do then is you don't make the diagnosis, and this is a developmental problem. We have time to make the good diagnosis. So it is not unusual to say, wait and see how this kid does. Let's see if third grade works out for this kid, if it really is a clash with the teacher. I'll tell you, sometimes it is, often not. So it's the importance of getting multiple good informants and a consistent history over time. So it's not, does that make sense? So this is asking about are there ethnic disparities in the rates of diagnosis of ADHD? And actually until, and it's a complex story. So what I can tell you what the disparity, because I recently looked into this. So throughout the 1990s, I think there was definitely underdiagnosis in black children. And the reason you can say that is there were some very excellent studies done in elementary schools which did teacher ratings of hyperactive and inattentive-like behaviors, and then looked at the rates of ADHD diagnosis, and they were much lower in black kids. That hasn't held with time. So the recent CDC estimates do not show a race or ethnic difference. What they do show that is holding with times is the subgroup who are really consistently being underdiagnosed are households in which the language spoken is not English. And that speaks to access to healthcare assistance. That is the disparity that is holding with time and hasn't budged at all.
Yeah. My question is, several of your diagnoses too seems pretty similar to another symptom like high functional autistic, or some people call it Asperger syndrome. So how do you differentiate the ADHD versus this problem? And some people were treated with Ritalin before they found that actually they are not ADHD.
want to take, or like Max? Yeah, Max. Yeah. 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 Yeah.
I think so the question is really, can you differentiate autism or autistic findings and features in children or adults from inattention and hyperactivity? And I think the short answer is probably yes. And that really depends then on not just one person saying it, but having a healthcare professional who understands the issue. I do think there are differences there, and I don't mean just genetic differences, which of course are there as well, but I do think there are behavioral differences between autistic, and you're talking about high-functioning autistic individuals versus individuals who are high-functioning and who have ADHD. I think, yes, even though there is no easy test, no blood test, but I think between questionnaires that are filled out from different observers, parents, teachers, and then when the children can do that themselves, you can differentiate there.
So, you can only trust clinical observations up to impressions to a limited degree. But my clinical impression is that when I was growing up, although in contrary to what you said, my grandmother told me, you're never going to grow up, so I am worried about that. But as I was growing up, I don't remember anything like this. I don't remember any classmate, anybody. And then suddenly there was this epidemic. It almost seems, and I'm exaggerating it, as if everybody's got ADHD. I mean, when 40% of the kids in a very fancy high school are on Ritalin, where were they before? Did they exist before? To some extent, is this something that we have created? Now, you're taking people that fit the criteria. This is pneumonia due to pneumococcus. I mean, you're fitting the criteria to fit it. But out there in society, most of the people who have the diagnosis, I suspect, don't fit that criteria. They can't be. Can it be that 40% of the kids in a school or 20%? Or even, your figures across the board? I find that amazing. What do you think?
Yeah, actually, it's an interesting, because certainly the school I was in, we didn't have ADHD in Northern Ireland. We still scarcely have ADHD in Northern Ireland, I can tell you that. But what we had instead were naughty children, and they had an awful time, and no one liked them, and they always were sat in the back of the class, and then the teacher would hit them with a blackboard, you whack them. And these kids, looking back, I am pretty sure if our whack of those kids had ADHD, no one did diddly squat for these children. They were just marginalized in the classroom. So I think the much more compassionate understanding that there is a biology to this is a good thing. And we, in the battle, we can't throw out the baby with the bathwater. And that is a real issue, because I think there is undoubtedly sometimes misdiagnosis of ADHD. And there's undoubtedly sometimes the use of stimulants as a cognitive enhancer rather than a treatment. That said, both of those said, ADHD is very real, very impairing for an awful lot of kids, and stimulants can make a huge beneficial impact on their life. It's just getting the right kids and the right diagnosis.
Just going to say that we have the same change that you described in the autistic spectrum. That is, it's now one out of 100. It used to be much, much less. So there was a descriptive difference in what fits into the syndrome. And I don't know if that's legitimate or not, but that's what in fact happened. I don't know if it's happening in ADHD too. The fact of the matter is, I understand it's the 40%. It's very different than the 6% that you say is average in the population. So someone ought to look into that school.
Yeah, I have a question. What is with the adults? I saw your study stop at 25. What is with the adults? And they say we didn't have this in the old days. I think you had it in the old days too. What is with these people who were born in the 50s and 60s, and they still there, and they still have ADHD? They stand in the checkout line at the grocery store, and they do this. Sometimes I see them, and I see they stay there, and I know they have ADHD. It's so typical, this behavior, and they are grown-ups. They are 50, whatever, and they still have it. So who takes care of them? They still don't have friends. They are still not very liked from other people. You know, they are still the same, wiggly.
Well, first of all, I would say, if there isn't a problem, a real problem, you don't fix it. If you're just jiggling around in a supermarket queue, it's fine. Whatever, you'll get over it. If you're losing, if you're losing your job because you're so impulsive, you can't complete the simplest of tasks. You can't hold out a job. You've had bouts of substance misuse because you're medicating yourself. You've had depressive episodes because you just feel like a big old failure. And no one has diagnosed ADHD because it wasn't around. It is not impossible to diagnose it in adults. It's a lot more complicated, and certainly you rely upon good informants to get an early and a lifelong developmental history, which is one of the delights of doing a family study where they all tell tales on each other. So it's great, it's great. So no, absolutely. So certainly the rates of diagnosis in adults are going up. I think they're not startlingly going up. They're going up to where mathematically I think they seems reasonable. So there are services.
I couldn't agree more with what you just said, Philip. And just to answer your question, I mean, those people who are in the AARP category, or in the over 50 category, and who get the AARP magazine, there's every 5 issues. There's an article on ADHD and diagnosing ADHD in the elderly and diagnosing and treating it in the elderly. I think the point that I wanted to make is that those people who have ADHD and who are impaired by it need to be recognized that they have a disorder, and that they have a disorder that can be treated. And I think not treatment, to me, that's healthcare disparity. And I think the NIH, what the NIH is all about, it's not about over-medicating 40% of children of well-to-do, of those kids who are Harvard-bound and the likes, but it's really those who have an impairment. And I'm always reminded of our colleague Javier Castellanos, who is a child psychiatrist, who says that it's hard to tell, like at 6, 7, or 8 o'clock in the morning, is it still night or is it day? And the same thing in the evening. It's like getting dark now, you go out, is it night or day? But no one will have any problems to tell at 1 o'clock, it's daytime. Of course it's daytime. Or it's 2 a.m. in the morning, it's nighttime. So yes, you can make the diagnosis of ADHD, and when you can, I think those children and adults need. And the short answer is yes. You can tell ADHD from not ADHD apart. Are there individuals? Is this a little bit like cholesterol or like blood sugar, like height? And the answer is yes. And are there gray areas there? And the answer is yes. But in the most cases, you can tell a cholesterol of 300 is too high. A cholesterol of 150 is fine. A cholesterol of 205 may be borderline. So the short answer is the research is there, yes.
Okay, listen, I want to thank both of you for a very, very exciting and stimulating